recording the webinar. So hi everyone, this is the IUSD Canada webinar. Today we'll be hearing from Mandana Vahabi on HPV self-sampling among sex workers. So Dr. Vahabi is a full professor and women's health research chair at the Lawrence Bloomberg Faculty of Nursing, U of T, and Unity Health Toronto. She's also an ICES scientist, a fellow of the Canadian Academy of Nursing, an adjunct professor at Toronto Metropolitan University. Her research is centered on promoting equitable access to primary health care with a strong focus on addressing cancer screening disparities among structurally marginalized populations. Dr. Vahabi collaborates both locally and globally with community stakeholders, leading large cross-sectoral and multidisciplinary teams to develop and implement innovative interventions aimed at advancing health equity through socially engaged research and knowledge mobilization. Dr. Vahabi employs a broad range of research methods, including mixed methods and participatory action research. So Mandana, you can take it away.
Thank you so much, Anna, for that nice introduction. I'm just going to share my slide now. I hope you can all see my slides.
Yep, we can see them.
Thank you so much. So first of all, good afternoon, everyone. I am really excited to share one of my study which focused on promoting cervical cancer screening among marginalized population, namely sex workers and individuals with a history of incarceration in Greater Toronto area. But before diving into the specifics of this project, I would like to provide some context about my program of research. As a community-based researcher, my work centers on improving access to primary healthcare for a structurally marginalized population, with a focus on cancer, mental health, and sexual health. Over the past decade, I have concentrated mainly on promoting the uptake of cervical cancer screening, both locally and internationally, by co-developing community-informed intervention for underserved individuals with cervix. In today's presentation, I aim to achieve three main objectives. First, I will provide an overview of cervical cancer and highlight the importance of regular screening, with a particular focus on the recent transition in Ontario from Pap test to HPV testing as the primary method of screening. Second, we will examine the structural barriers that prevent many marginalized populations from accessing screening services. Finally, I will discuss the role of HPV self-sampling as a promising strategy to overcome these barriers. Here, I will present findings from one of my studies, which is called Breaking Barriers, which demonstrates that engaging peer associates, individuals with lived experience of sex work and or incarceration, building a strong community partnership, and offering HPV self-sampling can significantly increase cervical cancer screening uptake among equity-deserving groups. Cervical cancer is preventable and treatable when detected early. Yet it remains one of the top 5 cancers among people with a cervix aged 25 to 44 in Ontario. Since 2015, cervical cancer has become the fastest rising cancer in this group, increasing by 3.7% each year, the first major rise since the 1980s. Canada's cervical cancer incidence rate is 8.4 per 100,000, more than double the World Health Organization's elimination threshold of 4 cases per 100,000. The primary cause of cervical cancer is human papillomavirus, which is the most common sexually transmitted infection worldwide. Fortunately, regular screening can make cervical cancer almost entirely preventable, as it allows to detect precancerous changes early and treat them before they progress to invasive cancer. Cervical cancer does not develop overnight. It has a long precancerous stage, which means there is usually a 10 to 15-year window between the initial HPV infection and the development of invasive cancer. HPV itself is extremely common. About 80% of people will be infected at some point in their lives. The good news is that in more than 90% of cases, these infections are cleared naturally by the immune system within 6 to 18 months. There are over 100 types of HPV, and roughly 40 of these can infect the genital area. HPV types are classified as low and high risk. The low-risk types cause genital warts, while high-risk types such as 16, 18, 31, and 45 are associated with cervical cancer. It is important to note that not everyone with a high-risk HPV infection will develop cervical cancer. The real concern is when high-risk types of HPV persist. Persistent infection, especially with oncogenic strain like HPV 16 and 18, is the main driver of cervical cancer, and these two types account for about 70% of cases. The remaining cases are associated with high-risk types 31 and 45. So this long window period, combined with the fact that most infections resolve on their own, highlights why screening is so effective. Screening allows us to detect a small proportion of persistent high-risk infections and intervene well before cancer develops. When we talk about secondary prevention, we are focusing on early detection, identifying precancerous changes before they progress to invasive cervical cancer. The World Health Organization currently recommends three main screening methods. The first is HPV testing, which is now considered the most effective approach. The second is cytology, which includes the traditional pap smear and liquid-based cytology. And the third is visual inspection with acetic acid, VIA. VIA is low-cost option that is primarily used in low and middle-income countries, often in combination with pap test, where laboratory infrastructure may be limited. In higher income settings like Ontario, the shift is moving toward HPV testing as the primary screening tool, given its high sensitivity compared to cytology. When we compare the two main screening methods, there are some key differences in what they detect, how they are collected, and how often they are recommended. Pap test, or cytology, looks for abnormal cell changes on the cervix that could potentially develop into cervical cancer. It has to be done by a clinician, a doctor, or a nurse practitioner, usually in a medical setting. The recommended frequency is every 3 years. On the other hand, the HPV test detects high-risk HPV, the virus that can cause abnormal cell changes. Like the pap test, it can be done by a clinician in a medical setting, but it also has another option, HPV self-sampling, where the person with a cervix can collect the sample themselves at a time and a place that works best for them. This flexibility can help remove some of the barriers that prevent people from getting screened. When done by a clinician, HPV testing is recommended every 5 years, according to Ontario guidelines. Overall, HPV testing is more sensitive than the Pap test, offers flexible collection options, and supports longer screening intervals. That is why it is such an important tool for increasing screening, especially among people who are under or never screened. This slide illustrates the steps involved in collecting an HPV self-sample, as well as the different types of brushes that can be used to collect the sample. This slide highlights how Canadian provinces have been adopting HPV testing as the primary cervical cancer screening method. Some provinces, like British Columbia and Prince Edward Island, were early adopters and even offer HPV self-sampling. Others, like Ontario, transitioned later in the spring of 2025 and still don't offer self-sampling. And then there are provinces that are still considering or planning to adopt HPV testing. Not being able to access HPV self-sampling through provincial programs can make it harder for some people with cervix, especially again those who are under or never screened, to actually get screened. So not everyone in Ontario has the same access to cervical cancer screening. Some groups are consistently under or never screened. This includes immigrants and refugees, Indigenous people, Black and other racialized communities, people with a cervix who have disabilities, 2S LGBTQ plus individuals, and sex workers or people with a history of incarceration. Our target populations, which namely are sex workers and people with a history of incarceration, face significant barriers to accessing cervical cancer screening. Many individuals in these groups do not have regular access to primary healthcare, which can lead to delays in receiving necessary screenings. Criminalization of sex work in Canada also creates barriers. Canada follows the Nordic or on-demand model, where selling sexual services is legal, but purchasing them is not. This can make sex workers hesitant to disclose their occupation to healthcare providers, fostering a stigma and mistrust in the healthcare system. As a result, some may avoid seeking preventive care, including cervical cancer screening. Discriminatory or judgmental attitudes from healthcare providers during medical encounters can further discourage people from seeking care. Finally, limited access to culturally safe, trauma-informed, non-stigmatizing, and inclusive health information makes it harder for people to get the information they need to make an informed decision about their own health. Our study focused on people with a cervix who were current or former sex workers or had a history of incarceration. We targeted this group because, as we discussed earlier, they face multiple barriers to cervical cancer screening. To address these challenges, we explored a low-barrier screening approach, which is HPV self-sampling. As mentioned earlier, it is self-administered, simple, and convenient. People can do it at a time and a place that works for them. This approach helps overcome the barriers we mentioned earlier by reducing a stigma, avoiding negative experience with healthcare providers, and improving access for those who might otherwise not get screened. It also gives people autonomy and a sense of safety. For our study, we used an online community-based mixed method designed to explore how acceptable and feasible HPV self-sampling is for promoting cervical cancer screening among under and never screened people with a cervix. We enrolled 84 participants aged 25 to 69 who identified as current or former sex workers or had a history of incarceration, lived in the Greater Toronto area, were able to speak English and either had their own computer or mobile device with internet access or were willing to travel to one of our collaborating agencies. We recruited participants through peer associates who were current or former sex workers with or without a history of incarceration, referred to us by our partner organization, namely Maggie's Toronto and PASSN. Our peer associates were trained on the study protocol, eligibility criteria, ethical considerations, cervical cancer and screening. They informed potential participants about the study and referred those interested to our project coordinator who explained the study, screened them for eligibility, and sent a link to give consent and complete the online survey questionnaire. Once participants finished the survey, they received links to educational materials and short videos on cervical cancer screening created by Cancer Care Ontario and Ontario Health. Participants who chose HPV self-sampling also got a short instructional video created by our team. It is important to note that our survey included a question asking participants if they would be interested to participate in a follow-up focus group. Those who expressed interest were then contacted by our research coordinator to arrange participation. Overall, data collection involved a questionnaire and a focus group, allowing us to get both quantitative and qualitative insight into the acceptability and feasibility of HPV self-sampling. Our online questionnaire assessed participants' knowledge, attitude, and practices related to cervical cancer and screening. Following these, participants were given the option to either try the self-sampling device or decline. Those who declined were advised to see their physician for a Pap test. Again, I would like to remind you that our study was conducted in 2024 and Ontario transitioned to HPV testing in the spring of 2025. So at that time, Pap test was the primary method of screening. So what did we find? From the 100 potential participants, 84 met our inclusion criteria. 40 were recruited through Maggie's Toronto and 44 through PASSN. Participants' age ranged from 25 to 69 years, with a median age of about 37 years. The age distribution was positively skewed, meaning the majority of the participants were younger, under 45 years, with fewer older participants. The majority identified as women, while 13% identified as non-binary, and 5% identified as two-spirit transgender masculine or genderqueer, reflecting a diverse population with respect to gender. About 66% were single or never married, and 46% had 1 to 6 children. Nearly half of participants were born outside Canada, coming from regions such as Africa, East, South, or West Asia, South America, and the Caribbean. Among these, 32% had lived in Canada for less than 5 years, 5% for 5 to 9 years, and the remainder for over 10 years. Regarding immigration status, 26 were refugee applicants, 15% were landed immigrants or Canadian citizens, and 5% were temporary migrant workers or visitors. Most participants had completed college or university, although 7% reported education of grade 9 or below. A majority were involved in sex work, primarily as independent escorts, followed by sugar babies and those engaging in survivor sex work. 33% had a history of incarceration, and 37% had been in sex work for 3 years or less, with the remainder reporting longer involvement. Looking at the clinical characteristics of our participants, About one-third rated their health as poor to fair. Around 50% had their first sexual experience at age 16 or younger. 25% reported 6 or more sexual partners in the past 3 months. Over half did not consistently use condoms. Nearly half of participants reported a previous sexually transmitted infections, including chlamydia, gonorrhea, and HIV/AIDS. Around 24% reported symptoms such as abnormal vaginal discharge, sores, or pelvic pain in the past 6 months, but only 40% sought medical attention. Of those who sought care, half were diagnosed with sexually transmitted infection. Our findings showed significant barriers to healthcare access. About half of participants reported challenges accessing healthcare, including long wait times, not having a regular family physician, and lack of OHIP coverage. Many relied on walk-in clinics, which were often perceived as inadequately equipped for comprehensive care. Participants described judgmental attitudes from healthcare providers, long delays for mental health services, and difficulty finding providers who were sex worker friendly, 2SL, LGBTQ plus inclusive, and committed to anti-racist practices. Many participants reported feeling uncomfortable disclosing their sex work or criminal history to healthcare providers. Rich stories were shared by our study participants about the practical and structural barriers they faced when accessing healthcare. Long wait times and limited availability of physicians came up a lot during the focus groups. One participant said, "I think a walk-in clinic can do for me better, because if you are to see a personal doctor, you must book an appointment. I have not yet been able to see my doctor for the last 6 months. I am still on a waiting list." Some participants also described feeling minimal engagement from their primary care providers. As one explained, "My doctor hasn't spoken to me since COVID. My health card expired." And for some, the trauma involved in even booking an appointment, often related to disrespectful or judgmental attitudes they faced, was enough to stop them from seeking care, as it is reflected in one of the participants' response. "Sometimes the trauma of even booking an appointment is enough to stop me from trying." These quotes highlight how system-level challenges, combined with negative experiences and attitudes in healthcare, can prevent people from accessing the care they need. We found that our participants' knowledge about cervical cancer and screening was generally low to moderate. About half of the participants had limited understanding of cervical cancer and its early warning signs. Many were unaware of symptoms, including post-intercourse bleeding, spotting between periods, postmenopausal bleeding, and pelvic pain. Screening guidelines were unfamiliar to most. Participants didn't know that testing is recommended every 3 years, starting at age 25 for sexually active individuals. We also heard a lot of misconception about cervical cancer screening. For example, some participants believed Pap tests were only needed for older women, or only when they had symptoms like an infection or bleeding. A few even worried that Pap tests could actually cause cervical cancer. And some participants were not able to distinguish between uterine cancer and cervical cancer. They felt they were the same. Participants also talked about limited access to clear, accurate, and personally relevant information about cervical cancer and screening. One participant put it this way: "All those things, we definitely don't receive enough education. There is definitely not enough information out there that is easy to find, that you have to kind of like carve around to find." Another highlighted the lack of specific practical information about sexual health and risks, saying, there is a bunch of things that can happen to my body from having sex and doing sex work. The problem I have is I have no breakdown of what those things look like physically and verbally because people have taboo around that. So I can't access those things. These stories really emphasizes the need for targeted, accessible, trauma-informed, and non-stigmatizing health education that address people's realities and experiences. Without this, many are left to navigate their health in the dark. Beyond access challenges, participants also faced a stigma and discrimination, which affected their use of healthcare services. A significant portion of participants reported internalized stigma and anticipated stigma from society, including family and friends, due to their involvement in sex work or having a criminal record. About one-third of participants agreed or strongly agreed that they had experienced enacted stigma, such as being denied access to health services. Over a third reported verbal harassment and judgmental attitudes from healthcare providers, including negative remarks or gossips while seeking health or social care. Participants described personal experience of stigma, judgment, and fear when accessing healthcare. One participant shared the anticipation of trauma during medical visit. For instance, one of the focus group participants stated, every time we have to go into a clinic to see a doctor to deal with these issues, sexual health, it is like a potential trauma. You never know how it's gonna go, what doctor you are gonna get, what doctor you're gonna to get. Experience of disrespect and disregard were common. As one participant said, you can get really disrespected, like I have had people being very disregarded to me. Some participants reported that healthcare providers use fear or moral judgment related to cervical cancer, HPV, or STD. One participant stated, having been a sex worker, doctors kind of use HPV, cervical cancer, STDs to scare you into like a more moral line of work. It is frustrating, disappointing, makes me mad. Others explained gaslighting or disbelief. Doctors will gaslight you because they don't believe in sex work. The emotional impact of such interaction was profound, as reflected in the following statement. They told me they were like, you have 75 to 80% chance of getting cancer. I was just in a completely scared mindset. Sometimes it feels like, I don't know, closes eyes. I just want to add on to that the fear from doctors. These narratives highlight how a stigma and a judgment in healthcare setting create barriers to care, discourage disclosure, and intensify fear, which can prevent people from undergoing a screening. This slide shows the cervical cancer screening outcomes. Initially, among the 84 participants enrolled in the study, 77 showed interest in using the HPV self-sampling kit, while 7 declined. Of the 77 participants who opted to HPV self-sampling, 3 failed to attend their pre-scheduled testing appointments. Ultimately, among the 74 participants who successfully completed the test, a third, 22, tested positive for HPV. Furthermore, 18% had high-risk HPV types, 16 or 18. So in our study, 88% of participants opted for HPV self-sampling, indicating high acceptability among the target population. Key motivators for choosing HPV self-sampling included privacy, ability to do the test without exposure to judgment or stigmatizing healthcare environments, autonomy, individual could take control of their own health screening, reduce stigma, avoiding potentially uncomfortable interaction with healthcare provider. These findings highlight that HPV self-sampling is both feasible and highly acceptable, and it has a strong potential to increase screening uptake among marginalized population. The following excerpts clearly shows that HPV self-sampling provided a sense of control, privacy, and reduced anxiety compared with traditional clinic-based screening. For instance, one participant highlighted its accessibility for trans men and those with body dysphoria or a history of sexual trauma. Another participant emphasized autonomy and avoiding judgment from healthcare provider. The following statement shows that HPV self-sampling enabled them to be in control and feel empowered. I am able to be in control of the process and not have another touching my body, and being able to seek care for a diagnosis as opposed to having well-to-do doctors trying to impose their values or expectation upon you during their diagnosis care process. Based on the study findings, we recommend several key actions. First, it is critical to address systemic barriers such as stigma and healthcare discrimination. This requires a twofold approach. On one hand, medical, nursing, and other health professionals' education at universities and colleges should embed culturally safe, trauma-informed, sex workers-friendly, 2S LGBTQ plus inclusive, and anti-racist care into their curricula. On the other hand, ongoing training for those already in practice is equally important to ensure these principles are actively applied in care setting. Second, co-development of accessible, user-friendly educational resources on HPV self-sampling, HPV, cervical cancer, and screening with communities would be essential. These educational resources must be clear, inclusive, non-judgmental, free of fear, and culturally and linguistically appropriate to address the specific learning needs of marginalized people. Third, ensuring follow-up care and support for individuals who receive positive test results is important. This should include timely medical follow-up as well as psychological and social support to address anxiety or trauma related to a screening and diagnosis. Finally, including HPV self-sampling as part of cervical cancer screening guidelines is imperative. This approach not only promotes access to underserved population, but also ensures continuity of screening during crises such as COVID-19 pandemic. Promoting self-collection or self-testing for HPV and other STIs like HIV allows individuals to take control of their sexual health in a safe and convenient way. This is particularly important given the rise in sexually transmitted infections in Canada since the pandemic. Incorporating these self-testing options into standard guidelines empowers people, increases screening uptake, and strengthens preventive efforts across the population. Together, these recommendations can help reduce cervical cancer screening disparities and advance health equity among marginalized communities. This concludes my presentation. I would be happy to answer any question you may have. Thank you for your attention.
Thank you so much, Mandana. That was a great presentation.
Thank you.
Just to our audience, if you have any questions, please put them in the chat or in the Q&A function. Maybe while we're just waiting for a couple of the, getting a couple of questions in, maybe I'll quickly start with one. Did people have any suggestions on where, given that a lot of the participants couldn't access healthcare or they were not wanting to go to see a healthcare provider, where could they access these tests?
Well, that's a very good question, Anna, because we did ask them how would they like to receive, this kind of self-testing options, and their suggestion varied. Some would suggest to pick it up from pharmacies. The others would actually suggest going to the community centers that serves their interest, and they are frequent those places most often. And these two were really highlighted, the community organization and pharmacies, according to our participants, were the best option for them.
Great, thank you. There are a couple questions or comments from Mark Steven in the Q&A. So I think this one's more of a comment. The HPV infections are not cleared, but they're controlled by the immune system. See this recently published IPV, International Papillomavirus Society position paper published in AJOG, and he's got the link there if anybody would like to see. But then he has a follow-up question. Maybe I've missed it. What lab did the test and who paid for the HPV test? Because you were doing these tests before Ontario said that they would include them.
Yes. So the lab was Mount Sinai's lab, Mount Sinai Hospital's lab, and also who paid for those tests. We did have a collaborator, and we used the kits from Roche. So they did pay for the kits as well as the processing charges for the lab results.
Okay, great. If anybody has any other questions, please put them in the chat or in the Q&A. Do you want to, I mean, you actually had really great representation, I think, from in your sample size. Could you talk a little bit more about like some of the community engagement strategies that you used in order to recruit such a high number of participants?
So actually, I have to say that we have recruited participants in a very short period of time. We thought that would be very challenging. But I guess the reason that we were able to recruit participants so fast was that we use, first of all, the organization that we approached included Maggie's Toronto and Passen, that they actually serve this population that we were targeting. And through them, we have actually recruited peer associate or community champions, people who are already in sex work or have a history of incarceration. And they were the ones who we trained, and we spent about half a day training and explaining all the things. And they did some rehearsal kind of, mocking kind of a recruitment process. And then after that, they were the one who would be, recruiting potential participants for us. And to our surprise, they were really fast in doing that. And we only took about 4 months to do the whole, recruitment, testing, and also holding the focus group after that.
I love our community organizations. They're so great when it comes to recruitment. I mean, we're recruiting for an anal cancer screening right now, and it's kind of gone through the AIDS service organizations. Unfortunately, it is kind of an open public link, so we've actually had quite a few fraudulent participants
Oh,
who
I
are
see.
trying to come in. But I think, yeah, using the community organizations is it's so helpful in getting real participants.
And we were really worried because it was done, online. And we didn't know whether they do have access to computer or mobile devices and internet and all those things. So what we did is that we did ask our collaborating agencies if they could provide a space for us with computer available there. So then they could come there and, access our site and do the questionnaire and also look up the videos and other informations that we are sending them. And some of the participants actually chose that route and they didn't have any problem about it. We did compensate for their participation in our study. So when they, did the questionnaire, we did pay them $90. And for the focus group also, we paid them $50, which really covered the expenses for internet usage for those who had the computer and they wanted to actually use their own, and they were able to commute to the places that some of them they prefer to do the test at those organizations rather than do it at home, because the whole idea of the HPV self-sampling is that you can actually conduct it at the privacy of your own home at a place that is more convenient to them. So I believe maybe because of their living condition, many preferred to come to those agencies to do the test rather than to do it at home.
Right. There is I think it's another comment from Mark in the Q&A saying, inspiring research and congratulations. Thank you, Mark. There is another question in the chat that I can see. Does oral screening for HPV exist?
I am not sure about that.
Yeah, I'm not sure. Maybe I know Mark is an expert. I am not sure about that either. I think some people are looking into doing saliva testing for HPV, but I think that's more in the like lab
Testing,
stage
yeah.
right now. Yeah, it's being tested. Okay. Any other questions?
Or maybe while people are thinking about asking more questions, I think there were a few areas that I was very interested to pursue in other studies, because as like this project was funded by Love You Shoppers, which is and with a small amount of funds. So we felt that the information that these people were actually talking about, that is wasn't really clearly addressing their learning needs, what we can do to improve access to information that could really help them to understand the risk and how and what is the role of screening. So we are currently actually doing another study with the same group of the sex workers, but this time we are co-developing all the informations that the affected community members will feel important for their members to understand about the screening. And I really and it's going to be based on all the principles I was talking about, and it's going to be art-based, so more in graphics, an easy way to understand the information being provided. So this is also another project that we are actually doing, and it's being funded by Canadian Cancer Society.
That's great. I was actually going to ask you about that next. Whether or not the instructions that participants got for taking the self-sampling, was that mostly like graphical? It was written? Did the participants find it easy to understand?
So the steps that they have to take, I showed the pamphlet that is there in order to show how it's being done. We also created our own video of how it's being done, which we sent prior to the time of their testing. And when they came there, we provided another pamphlet with the easy to steps involved in the doing the test. And we were also there in case they had any issue. To our surprise, everyone felt it was so easy, and they were referring it to, COVID-19 testing. They said that it was much better than that. The only thing that they complained about the flimsiness of the actual brush. They said that it wasn't very hard, which shows that it's really a safe, tool for collecting the sample. However, they thought if it was firmer, it may have been easier to insert. but and which we have communicated to people who are actually creating this tool.
Okay. Was there any request to like translate those materials?
That is, I really am glad that you said you asked this question. As you have seen, we recruited people who could speak English, so there was no translation available, and we tried to have even people who, if they are not, immigrants, they could speak English. And that's another limitation of our study. So we don't really know how it's going to be receiving well by the people who do not speak the language. And I'm sure they have other challenges that we haven't really explored. But that's a very important issue because this study was conducted all in English.
Mhm. Yeah, and Toronto's so many people in Toronto speak another language other than English, and being able to use these kinds of instructions are so important to reach, especially a lot of those populations you were talking about at the beginning, the underserved populations, so like racialized groups, immigrant, newcomer. But I think it also works for people like when we think about Northern Ontario and how there's very limited opportunities. Like a lot of people don't have a primary care provider.
They don't. And
Yeah.
in our study, almost 50% of the participants didn't have a primary care provider. I mean, in a sense, they are really hesitant to use primary care providers because of all those abuses they face during medical encounter. But at the same time, having a permanent caregiver would be much better than, going to the, walk-in clinics. So that was another issue that we have come across. And again, we are really grateful to Hassle-Free Clinic because sometimes for those who didn't have primary care providers and they had to do and they were tested positive and they had to do the follow-up test with the physician, they accepted to provide the physician in order to do that. But it was a very challenging process. And considering that some healthcare providers, I mean, physicians are retiring soon, I mean, and they have, you don't even have the same kind of pool as you had before. So that's a challenge.
Absolutely. And I feel like that is kind of a challenge across all, primary care is the backbone of our healthcare system, but if we don't have providers, then it's very hard to get people to go if there's nobody available. There's no capacity. Okay.
And that's why it makes it much more important to have HPV self-sampling option for, people with a cervix. And I hope that Ontario Health and Minister of Health in Ontario try to include that in their guidelines because British Columbia right now is doing it. Princess Edward is doing it. Manitoba actually did some pilot regarding HPV self-sampling, and all the result is so positive, and participants all are saying that this is the best way of doing the test, and they were so happy about the use of HPV self-sampling. And yet, in Ontario, although apparently I'm hearing that there are a few sites who are doing pilot testing regarding HPV self-sampling, but it hasn't been implemented,
Mhm.
despite, a strong evidence of its effectiveness and acceptability and feasibility for underserved. And
Mhm.
not only underserved, as I mentioned, during the crisis, I mean, so many people weren't able to do, I mean, general population, I mean, couldn't really do their cervical cancer screening test done because of, closure during the, COVID-19 pandemic, which makes it even more important to look at other options where people should not really left behind and be able to do other kind of tests that proven effectiveness, like HPV self-sampling, like HIV testing, for example.
Absolutely. And I wonder, hopefully somebody's doing a health economic evaluation of this somewhere because I feel like it is
Anna, it
more
has
cost
been
effective.
done. It has
Okay.
been done. Everyone is saying it is effective and it's cost effective. But I think change, it really takes a lot of time to happen. And I have been writing commentary, talking to people, trying to, persuade them, before even that transition in spring of 2025 to include HPV self-sampling. I mean, I really admire British Columbia, who has always been, more advanced in undertaking innovative approaches, which really benefits not only general population, but also those marginalized, those equity deserving groups. So hopefully Ontario will move in that direction soon.
We can only hope, Mandana.
Exactly.
Okay. All right. So I'm not seeing any more questions in the chat or in the Q&A. So if there's no more burning questions, maybe we'll just end a little bit early, give 10 minutes back to everybody. Thank you so much for everybody attending. I'm just going to drop the link if people are interested in registering for the next webinar, which is on Wednesday, November 12th at 12 p.m. Eastern Time with Scott Gray Owen. This is more of a microbiology. Oh, sorry. Apologies, I put the wrong link in. There you go. So if you're interested, please go ahead and register for the webinar. But everyone else, thank you very much for attending today. It was a great conversation and great presentation.
Thank you again, Anna, for inviting me. Thanks. Have a lovely
Thank you.
weekend. Bye.
Bye, everybody.